Hey there, nursing students. Welcome to this Master Review Explainer for NSG 331. Look, I know you've got a ton on your plates right now, but today we're going to lock in the exact knowledge you need to absolutely crush Dr. Kuykendall's Week 8 quiz. We'll be taking all those complex physiological changes of aging and breaking them down into clear, actionable clinical judgments. So, grab your notes, get comfortable, and let's get ready to conquer chapters 12 and 14. Okay. Here's our game plan for today's study session. We've got 1. Urinary elimination changes. 2. GI tract and bowel function. 3. Skin, hair, and nails. 4. Skin conditions and cancers. And finally, 5. Pressure injuries and clinical judgment. Let's get to it.
But hey, before we dive into the heavy clinical data, take a deep breath. Seriously, take a second to remember exactly why you're here. Nursing school is incredibly tough, but you know what? You're tougher. Let's set a positive tone, shake off the stress of the week, and get laser-focused on your goals. You've totally got what it takes to master this material.
All right, starting right up with Section 1, Urinary Elimination Changes. So, the absolutely crucial point here is understanding your patient's physiological baseline as they age. Because let's face it, you can't identify the abnormal if you don't know the normal. As patients get older, their renal blood flow and glomerular filtration rate, or GFR, significantly drop. The bladder itself kind of loses its tone and elasticity, which means its capacity shrinks. Because of this, patients often deal with incomplete emptying, an increase in post-void residual volume, and a loss of that normal daytime rhythm. All of that leads directly to nocturia, waking up multiple times in the middle of the night to urinate.
Now, listen closely. Urinary incontinence is not just a normal part of aging. You absolutely have to be able to differentiate these types of incontinence for your exam. Notice the distinct triggers. Stress incontinence happens with exertion, like sneezing or coughing. Urge is preceded by this sudden, intense need to go. But I really want you to focus on differentiating functional versus transient incontinence. Functional means their urinary tract actually works just fine, but a physical disability or maybe a communication issue prevents them from reaching the toilet in time. Transient, on the flip side, is a temporary leakage caused by a passing situation, like an acute urinary tract infection or a brand new medication.
When it comes to nursing interventions, it's super important to remember that continence care is actually a major quality of care indicator, especially in skilled nursing facilities. As nurses, our interventions can literally change a patient's daily quality of life. You're going to want to prioritize scheduled voiding and bladder training. Teach your patients pelvic floor muscle exercises, commonly known as Kegels, to strengthen that sphincter tone. And don't forget the lifestyle changes. Things like modifying when they drink fluids, managing bowel regularity to keep pressure off the bladder, and reducing weight can all make a massive, massive difference.
Let's test your recall right now with a clinical scenario pulled straight from the text. A 92-year-old man in the ED discloses that he dribbles when he urinates. So, is this dribbling due to his diet, simply his old age, laziness when urinating, or an underlying cause like an infection? Well, if you remember our chat about transient incontinence just a second ago, you know the answer is an underlying cause, like an infection. Never ever dismiss incontinence as just old age. Moving right along to Section 2, GI tract and bowel function.
Now, what's really fascinating here is that constipation isn't just caused by the aging of the GI tract itself. Sure, peristalsis slows down a bit, but the real culprits are usually precipitating factors. Think about the common causes we see in the elderly. Medication side effects like opiates, NSAIDs, calcium channel blockers, and iron supplements are huge contributors. Combine those meds with immobility, a fleeting urge to go, and decreased fluid intake, and wow, you have the perfect storm for severe constipation.
Let's walk through the step-by-step clinical pathway for treating normal transit constipation. Notice we don't jump straight to the heavy-duty meds. We always start with increasing fiber intake, fluids, exercise, and maybe some magnesium hydroxide, milk and magnesia. If those symptoms don't clear up, then we graduate to adding a stimulant like bisacodyl. If it's still being stubborn, then we look at polyethylene glycol. It's really all about a systematic step-up approach.
But what happens if that constipation is mismanaged or ignored? Well, it leads to fecal impaction, which is a severe and really painful complication. Basically, a large, hard mass of stool gets stuck in the rectum, and sometimes you'll actually see liquid stool leaking around it. Honestly, this is tricky because it can easily be mistaken for diarrhea. This is especially common in institutionalized older adults or those taking narcotic pain meds. Your physical assessment and a thorough bowel history are absolutely critical to catching this early.
Time for another quick quiz check to keep you sharp. If you're setting up a bowel retraining program for a patient in an extended care facility, Which intervention do you include? Do you limit fluid, administer daily enemas, reduce high residue foods, or do you toilet the patient at the exact same time daily? The correct nursing action is toileting the patient at the same time every single day. This establishes regularity and leverages the body's natural gastrocolic reflex.
All right, on to section 3, skin, hair, and nails.
You really need to have a clear understanding of the difference between the skin layers for your quiz. In the outer layer, the epidermis, melanocytes decrease. This makes the skin look paler and more translucent. However, they can also clump together to form lentigens, which are those benign age spots. Now let's dive deeper into the dermis. This is where the real structural integrity is lost. The dermis gets thinner, it loses its stretch and elasticity, and the capillaries become incredibly fragile. On top of that, sebum production drops, which leads to overall much drier skin.
Next up, Section 4, Skin Conditions and Cancers.
Pay really close attention to this presentation of herpes zoster, which we commonly call shingles. This is actually a reactivation of the chickenpox virus, very often triggered by stress, an illness, or just an aging immune system. Notice how that vesicular skin eruption strictly follows a dermatome, a nerve pathway, and it usually stays on just one side of the body. It doesn't cross the midline. And remember what your patient will tell you. They'll often report severe itching, tingling, and pain for several days before the visible outbreak even pops up.
Now here's a very different issue, scabies. This is caused by a tiny burrowing mite that lays its eggs under the skin. You gotta remember that it is highly contagious and it spreads like wildfire in communal living environments. To officially diagnose it, a skin scraping is often used. And as a nurse, you absolutely need to know that the thick crusts on the skin can harbor those mites and eggs. Treating it means specific medications plus aggressively laundering all their clothing and linens.
Let's pivot to talk about trauma to that fragile, aging dermis we discussed earlier. For skin tears, your primary intervention is crucial. First, you're going to gently cleanse the area with normal saline. Then, you gently roll or return the skin flap back to its normal position using a gauze pad. But here's the major exam tip. You secure it without using regular, harsh adhesive tape. You must use non-adherent dressings and tubular gauze. If you don't, you run a huge risk of tearing that fragile skin all over again when you go to change the dressing.
Moving into oncology, try to group these 3 primary skin cancers in your head to keep them straight. Basal cell carcinoma is the most common one, and it usually pops up in older, light-skinned adults. Squamous cell carcinoma is the second most common, and it carries the highest risk of appearing on sun-exposed areas. Think head, neck, and hands. Finally, melanoma. While it accounts for less than 2% of skin cancers, it is by far the most deadly because it metastasizes, or spreads, incredibly quickly.
And for our final act, Section 5, Pressure Injuries and Clinical Judgment.
Did you know that older adults account for 70% of all pressure ulcers? It's true. Because they're incredibly costly to treat and heavily tied to Medicare and Medicaid reimbursements, prevention bundles are absolutely critical in your everyday nursing practice. These bundles require comprehensive programs. You've got to utilize the Braden scale to assess risk, meticulously manage their nutritional health because remember, malnourished skin breaks down so much faster, and rigidly adhere to repositioning protocols and support surfaces.
Let's lock in one final clinical scenario to test your staging knowledge. An older adult has an open sacral pressure ulcer. The wound bed is a pink-red color, adipose or fat, and deeper tissues are not visible. There is no sloughing. So what stage is this wound? Well, because it's open and pink-red but hasn't reached that fat layer, this firmly indicates a stage 2 pressure ulcer. Recognizing these subtle cues, that is exactly what clinical judgment is all about.
Excellent work sticking with this explainer. You've reviewed the upper and lower elimination systems, the whole integumentary aging process, skin conditions, and pressure injury protocols. To wrap things up, I want to leave you with this provocative food for thought from the text to ponder before your quiz. Considering all the physiological changes and potential discomforts we just went over, what factors actually impact rest, sleep, and activity as we age? Keep that critical thinking engaged. Best of luck on Dr. Kuykendall's Week 8 quiz, and I'll see you in the next review.